of medicine role. Here, a 40-year-old gentleman farmer by occupation from Chittoor came with the complaints of fever for 10 days and a bilateral knee pain for 10 days. Instead of presenting illness, the patient was apparently normal. Before 10 days, he developed low-grade intermittent, not associated chills and rigor, and bilateral knee pain for 10 days, which is insidious onset, gradually increasing in intensity, and not associated with. It was associated with the swelling and tenderness, and there was no ailing on stiffness, no deformity, and no other joint involvement. There was no chest pain, palpitation, no recent travel history, and no cough, no sore throat, no abdominal pain, no burning maturation, no trauma. Past history, he was recently diagnosed as a diabetes mellitus, and her latest HbA1c was 13.9. Person stopped alcohol for 10 years back and a normal bowel and bladder habits. Vitals wise, vital stable, the temperature is 100 Fahrenheit, and general examination ictus is present. There was no cyanosis, clubbing, and generalized lymphadenopathy. And local examination of the both knee joint, there was some warmth and tenderness present. There is some patellar tapsing was positive, and there is a restricted knee joint mobility and no crepitation, no neurovascular deficit. The systemic examination within normal limit. So here the summary: the 40-year-old gentleman presented with the symptom numbers of fever with the oligoarthritis because of both knee joint involvement. The differential we consider was infectious arthritis, mostly septic arthritis, and crystal-induced arthritis, and hemarthrosis because there is no trauma, and a systemic rheumatic disease like SLE, rheumatoid arthritis, but unlikely in this case because there is no CTD like dry mouth, like that. So there's an initial evaluation with the total count of 17,600 with the neutrophils predominant. HB was 11.2 and the platelet was 4 lakhs. And there was hyponatremia, and the urea rate was within normal limit, and LFT shows total bleeding was 4.46 and DARC was 3.76, and total protein was 6.9, albumin is 2.8, and SGOT is 15, and SGBT is 30, and alpha is 67. Urine routine shows there is pyuria, and other workup because of ictus and jaundice and joint pain, we consider lepto and chikungunya also on possibility because of outbreak. So that is also sent, that is negative. RBB is negative, and the HbA1c is 14.1. The next step of investigation, ultrasound MSK joint was done showing bilateral mild knee joint effusion noted with the fluid exchange into the suprapatellar fossa, and there is no evidence of synovial thickening. So they went into emergency knee joint aspiration, both knee joint aspiration. The WBC of the right knee shows 2,700, and the left knee was 17,000, and the RBC was 6,400 in the right knee, and the left knee was 1,090 with the polymorphs predominant, lymphocytes 2 in the right and 1 in the left, and there was no crystals deposited in the knee joint. So blood cultures grew, the multiple serial blood cultures was grown showing Burgdorfia pseudomyeli, and also knee joint aspiration shows same thing like Burgdorfia pseudomyeli. So these are the interpretation I want to reinforce. So whenever that knee aspiration, they have to look for grass appearance and send the aspiration for cell count and differential and crystals and gram stain and bacterial culture. First step in interpretation of synovial fluid analysis, first whether the hemorrhagic or not. If it is yes, rule out hemarthrosis like trauma, coagulopathy, and tumor. If it is no, look for next step is look for WBC counts. If it is more than 2,000, so work of for like inflammatory arthritis. If it is no, it like a non-inflammatory arthritis like osteoarthritis, trauma, and avascular necrosis. If it is inflammatory arthritis, yes, you would look for crystal, whether the crystal is present or not. If it is yes, then you rule out gout and pseudo gout and all. And if it is no, then look for a gram stain or a culture. So if it is positive, most likely it's a septic arthritis. If it is negative, like other thing is tuberculous arthritis, fungal arthritis, and inflammatory arthritis. So the patient is having a bilateral septic arthritis with Burgdorfia pseudomyeli. The other metastatic workup like CCT thorax abdomen was one that is normal, and echo is also no vegetation. Since the patient had an urine routine shows pyuria and also prosthetic tendon is also there. We have done a transrectal ultrasound showing a small hypoic collection in the left lobe of prostate is likely representing the small abscess formation. So not amenable to aspiration, it keeping the patient under follow. So final diagnosis is a bilateral knee septic arthritis with Burgdorf's pseudomyeli, newly diagnosed uncontrolled diabetes mellitus with metastatic workup like prosthetic abscess children. And the antibiotic assay was MACS meropenem 1, susceptible, doxycycline 0.9, and ceftazidime 2, Septran is 2. We got a positive culture on 610 and negative culture on 2010. So there was a persistent bacteremia because the first culture done on 6 was positive, and negative culture after 2 weeks only we got. So I want to just few definition I want to reinforce. What is persistent bacteremia? Rather than I didn't discuss about the epidemiology and bacteremia, microbiology of the bacteria. I just few definition I want to tell. What is how to calculate duration of bacteremia and what is persistent bacteremia? What is time to positivity in this case of bacteremia? What is how to calculate duration of bacterium is defined as the time between collection of first positive culture and the collection of last positive culture. This is called duration of bacteremia. What is persistent bacteria means blood culture that remains positive even after 7 days of effective therapy, as per its Infectious Disease Society of American guidelines. So in my patient, the first positive culture is done on 610, and the last positive blood culture was 1610. So more or less more than 7. It's called a persistent bacteremia. So in this patient, why persistent bacteria means because he has diabetes mellitus and ethanol consumer, and also bone involvement also is because of septic arthritis. So whenever the involvement of musculoskeletal joint, there will be a persistent bacteremia because of bone is high rich in vascularity. And also this is an article taken from the Tropical Medicine. It's a retrospective study. In the time period they follow is 25 years. There is in 477 patients diagnosed of positive culture amyloidosis. So in this case, duration of bacteremia among patients with the positive blood culture is also so the more among musculoskeletal involvement because one's like 116 hours. So what is time to positivity? For a blood culture, this is the duration of time that is blood culture specimen spent in incubating in the automated blood culture system before bacterial culture growth. So in this case, my first 6th 10th, that was time to detection is 12 hours. At the end of last blood culture positivity is 43 hours. So it's a directly correlate with the survival rate also because the other tableau claims of time to positivity is less than 24 hours is associated with the more mortality rather than time to positivity is like within 48 hours and 72 hours. So other information I want to reinforce the meropenem, ceftazidime. The treatment of choice in Burgdorf's amyloidosis either like meropenem or ceftazidime. And there is no added advantage of meropenem over ceftazidime in susceptible isolates. And also whenever the patient with the septic shock and the patient requiring ICU, we can give meropenem, but there is no evidence and also cost wise, usually the Burgdorf's amyloidosis is intensive phase and eradication phase. Intensive phase like 4 to 6 weeks and eradication is 6 months. So let's take duration is if you want to give ceftazidime is 2 grams, give 8 early. The 4x comes around for 84 vials. So it's cost around 36,000 and rather than meropenem is 84 vials is 82,000. So we can give ceftazidime in poor patient. So our patient with an adequate source control, we have done a bilateral knee arthrotomy and a washout was done, and also ultrasound follow-up was done, like prosthetic capsule because small collection is we have just follow the patient, and also medication we have started on ceftazidime 2 gram IV Q8 early and Septran because the Septran usually begin eradication phase, but in this case of involvement of musculoskeletal system, we can give ceftazidime as an adjunct therapy. And strict glycemic control and Piclin was placed and planned to shift to Russia for antibiotic continuation. Learning point is interpretation of synovial fluid analysis.
Thank you for your presentation. Any comments from the audience, Dr. Amit?
Persistent bacteremia. This is definition for tuberculosis.
Any bacteremia?
Any bacteremia. So for mycobacteremia also it persists. So that's probably a definition for a typical bacterial infection, right? Then typical bacterial infection that causes bacteremia are infections like gram-negative organisms and extra. For melioidosis, we know that it is atypical. How is it atypical? It is atypical because organisms is synthesis. It disseminates in substances. It requires prolonged treatment. It often requires combination. What else are atypical as compared to the usual or the typical bacterial? I'm not sure if the persistent bacterial definition that is defined right for normal bacteria should be applied to melioidosis or should come into play even when you're discussing melioidosis. Second one is you said that the first medical was 20 days later.
No, the 20th, sir.
The so-called persistent bacterial persistent.
This is more than 7 days. Like first.
Just show me the slide that summarized persistent bacterial. Wait. 6 to 28. Was the culture number 90?
This
Culture number 80.
no, so that negative culture report came on only 20th.
Sure. But was the culture number on 13th? You know what I'm saying? Your first negative culture was on 20th. You exactly don't know when the bacteria resolved, unless you have drawn culture every single day. Or you have a culture that is positive on 19th. Isn't it? So even if you were to apply the definition of persistent bacteria here, it will not apply because you do not.
Really, we didn't do
Right? Well, of course, you can say that 6 plus 7 is what? 13th, and there is a positive culture on 14th, then you can still probably say. But just because the fact that the first negative culture on 20th does not mean that it is persistent bacteria. I'm not saying that you should apply the definition of persistent bacteria. Even in a slide where you look at large series of patients where you have looked at the duration of bacteria, what was the mean duration of the entire cohort? The mean duration of bacteria for the entire cohort.
Steady, they have followed the patient who have followed 477 patients. They have followed.
Sure. Of the 277 patients, what was the mean duration of bacteria in patients who had bacteria? You said that people who had musculoskeletal involvement had a prolonged duration. What was the entire cohort? But how many days was it for the musculoskeletal cohort? I did not ask that. You want to go back to that same?
So multivariate analysis. One is standard.
116 hours. How many days?
5 days. 4 to 5 days.
They have done valid cultures every single day. How did they find out that was in hours? Every single hour they were. So there should be a caveat that which is discussed in the paper. You should see how they have defined the duration of bacteria. Because you are not doing every single hour. You can only say that first negative culture was one particular day. So you are assuming that it became negative that time. It may have become negative 1 hour earlier, 1 day earlier. So there are caveats to that. And I am not sure if this discussion of persistent bacteria should come into play at all when we are discussing atypical organisms. Rather than that, I wanted to ask you said that meropenem does not confer any additional pain compared to capacity, even in critically ill patients. It is not entirely true. There may not be evidence from randomized controlled trials, but even in the, remember right from Thailand, in a simple randomized controlled trial, there is no mortality benefit, but treatment failure was more destructive. It did not translate into a mortality benefit, which was the primary outcome, which is probably why they said no enough benefit. And there are multiple retrospective studies. There's a before after study from Australia where they showed that after introducing meropenem as the first line agent, there's a significant decrease in mortality in the recent years as compared to the past years when they were using calcium. Then, of course, there is medical advancement, all this also has happened. Our knowledge about medical system. So, may not be robust, first of all, best quality evidence, but there is still some evidence. So, critically, we should.
Thank you, Dr. Amit.
One point. Can you show the slide? This one.
This one.
Persistent bacteria culture. So your first culture on 6 is reported on 17. When I agree with that, probably for this we cannot call it persistent bacteria. Probably you should also tell us when you have, how long you have given effective therapy. The culture is reported on 17. When did you start meropenem? So we have a culture on 6, which is reported on 17. Then there's a culture on 16, which is reported on area. When did you actually give 7 days therapy and then do a repeat
Initially,
culture?
we started on like a meropenem.
From 6 is on meropenem.
Yes.
From the day it's
No,
admitted,
no, from the day admitted, we started on meropenem. After that.
so there's a culture sent on 16, which is still showing after 10 days.
Yes. Yes.
So you switched to ceftazidime on 17th when the first thing came.
Like on the fever, like still has fever spike. Like after like 1 week of meropenem, we switched to ceftazidime. Initially, we started on meropenem, and then after 1 week of this thing, like I went to the like they're actually very poor. Like I just see the cost of injection, and also this very low, so we started on the ceftazidime after 1 week of.
Ashes positive on 17. How did you shift to ceftazidime on 13?
I didn't understand.
Yeah, your reporting of this first bacterial culture is on 17th.
Yes, ma'am.
Did you have any previous cultures that have reported area before that? Or did this report come earlier and if there is a change in date, is that mentioned the same? Could all of this look like it's reported on 17th? Or passes on 12th? Sure.
Any other comments from the audience? Thank you for that presentation. We'll move to the next presentation from Medicine 2, Dr. Lino, the Eagle.